Foxy. On behalf of Team ICOG 2025, I welcome all of you for the first lecture of ICOG online lecture series for reproductive medicine. First of all, I congratulate you for thinking of reproductive medicine as your subspecialty and that you've joined the ICOG courses. There are some instructions which our staff has written in the chat box that we want your videos to be on and you need to rename yourself. It is important for you, not for us, because for those 2.5, 3 hours, we want you to focus totally on the classes that we are going to take. I welcome 4 coordinators who have agreed to look after the lecture series. Dr. Madhuri Patil, Dr. Pratik Tambe, Dr. Seema Pandey, and Dr. Poonam Goyal. Please understand that all 4 of them are very busy senior fertility specialists, and they are sparing their time just to make sure that the lecture series runs smoothly. So this lecture series is for you because we want you to understand the theory part as well rather than only doing the practical. The practical work you have to learn at your centers, and if there are any queries which are unresolved, you can ask these 4 people who are experts in this subject and they will solve all your queries. The reason we are taking these classes is to make sure that the teaching is uniform, and we have roped in all senior faculty who are practitioners doing fertility practice for many, many years. So happy learning to everyone, and please be particular in joining. For those 2 hours or 3 hours, make sure that you leave everything aside and attend these classes because these classes are meant for learning. If you look at the teaching program, each lecture is almost for 1 hour. So it is going to be like a proper class where our faculty will be teaching everything in detail. And in spite of 1 hour, if you feel that there are any things that you want, you can always talk to our coordinators and they'll certainly help you out. So my best wishes for this program and happy learning to all the candidates.
Yeah, I think we can start with the case presentation. So
Yes, sure.
You can share your slides, Vaishnavi.
Good evening, everyone, respected teachers. Today I'm going to present a case presentation on diagnosing the etiology of infertility. So this is a case. A 31-year-old female, a resident of RR Nagar, Bangalore. She's a software engineer by occupation, belonging to upper middle class. She's been married for 7 years, non-consanguineous marriage. She came with the chief complaint of inability to conceive since 4 years. She attended menarche at 15 years of age. Her past menstrual cycles were irregular. Flow duration was 3 to 4 days for every 1 to 3 months. The flow was moderate and chaining 3 to 4 pads per day. There was no dysmenorrhea. Present menstrual cycles are also irregular. It is similar to the past 3 to 4 days of flow and 2 to 3 months. Her LMP was on 1st October, which was after the withdrawal, which we have given her. Sexual history, the quarter frequency is 3 to 4 times a week. There is no history of difficulty during intercourse and no history of dyspareunia. Conceptive history, there is no history of any conceptive use. Coming to obstetric history, she had one abortion, which she conceived with ovulation induction drugs with tablet letrozole and timed intercourse. The abortion was induced at 7 weeks of gestation. In view of anembryonic gestation, it was medically managed. As medical history, she is a known case of hypothyroidism since 3 years and is on tablet Thyronorm 50 micrograms. There is no significant surgical history, no history of drug or food allergies. A family history, her father is a known case of cardiac disease. He underwent a bypass surgery. He's also known case of hyperlipidemia. Her paternal grandfather had a history of hypertension. Previous in treatment for infertility, she underwent 2 cycles of ovulation induction and timed intercourse with tablet letrozole. Male partner, he's 38-year-old software engineer by occupation. There is no significant past medical or surgical history. Social history, there's stress and exposure to toxic environment as he's been working long hours on laptop and exposed to Wi-Fi. There's no history of smoking or alcohol consumption. Family history is not significant. Coming to general examination, she was febrile. Her pulse was 66 beats per minute. She's normotensive. Her weight is 65.2 kg, height 161 centimeters. The BMI coming to 21.5 kg per meter square. Her waist circumference was 99 centimeters, hip was 95 centimeters, waist hip ratio is 1:0.4. There was no pale icterus or pedal edema. The cardiovascular system, respiratory system, and central nervous system appear clinically normal. Breasts were normal, thyroid is normal. There was presence of hirsutism, acne, and obesity. The secondary sexual characters were well developed. Coming to local examination, parabdomen was soft, non-tender. Perspeculum, cervix, and vagina was healthy. Bimanual examination, uterus was normal size and anteverted, fornices were free and non-tender. Ultrasound, which was done on day 2 of the cycle after the withdrawal bleeding, uterus was normal in size. Endometrial thickness was 8.7 millimeters. The right ovary measured 4.79 into 2.2 into 3.8 centimeters with increased stroma. The volume corresponding to 21.08 ml. And the antral follicular count was 35. The left ovary was also enlarged. It was 4.21 into 2.2 into 4.2 centimeters with increased stroma. Volume of 20.37 ml and antral follicular count of 27. Coming to diagnosis, this is a case of secondary infertility with polycystic ovarian syndrome. In view of irregular menstrual cycles, presence of signs of hyperandrogenism such as hirsutism and acne, and ultrasound features of polycystic ovaries. Evaluation, the basic blood investigations were done, which were normal. Complete blood picture was normal and lipid profile. Total cholesterol was 150 milligrams per deciliter. Triglycerides, HDL, LDL were normal. Glucose tolerance test was also normal. The viral serology markers were also non-reactive. Coming to the hormonal assay, bulk-stimulating hormone was 5.5 milli-international units per ml. LH was 7.19. TSH was 2.4 milli-international units. Prolactin was 14. AMH was 5.66 nanograms per ml. Total testosterone is 3.42 nanogram per ml. Sex hormone binding globulin was 26.9 nanomole per liter. Free androgen index coming to 1.99%. She has history of abortion and secondary infertility for 4 years of duration. Hysterosalpingography was done. The uterine cavity appeared normal in shape and contour. The right fallopian tube, both the fallopian tube were normal, proximal and mid-tube. Ampullary dilatation and coiling were seen. Distal folds were preserved. Femoral end was normal, and tubal pressures were not elevated. There was no obvious peritubal disease, and free spill was seen. Both tubes were patent with free spillage corresponding to category 2A. The semen analysis was done, and it was normal. The treatment we planned for her was we would counsel regarding the lifestyle modification as she was obese, and further the ovulation induction with timed intercourse with oral ovulogens. If there was resistance or failure for the oral ovulogens, then we were planning ovulation induction with gonadotropins and IUI. This patient came with 2 months of amenorrhea and anxious to conceive. So we had given withdrawal bleeding after ruling out pregnancy with Primalot N. On day 2 of cycle, ovulation induction was started with tablet letrozole 5 milligrams HS for 5 days. following which the follicles were monitored and ovulation was triggered when the dominant follicle was 20 to 20.5 mm with recombinant HCG 250 micrograms subcutaneously. Then timed intercourse was advised for her after 35 to 36 hours of trigger. The patient was called 20 days after timed intercourse. Level 1 beta HCG was done, which was positive, 1971 milli-international units per ml. The TVS was suggestive of single intrauterine gestation. The gestational sac was measuring 0.59 centimeters, corresponding to 5 plus 1 weeks of gestation. The right ovary was showing corpus luteum. After 1 week, the repeat scan was showing single live intrauterine gestation with mean sac diameter of 1.69 centimeters. Fetal pole was seen. Crown rump length corresponding to 6 plus 4 weeks of gestation. The cardiac activity was also visible. At present, the patient is 23 plus weeks of gestation with normal anomaly scan.
Yeah, so you did not, when was her abortion? How many years back?
It was 4 years back, ma'am.
So since then she's trying to conceive.
Since then, she's trying to conceive. She's not been using any contraceptive method since then.
Yeah. So what is the significance of the waist hip ratio and what is the normal value?
Normal value is less than 0.08, ma'am. Significance is in obesity, polycystic ovary, and in Indian ethnicity, the obesity is apple shaped. So the significant waist hip ratio indicates the dyslipidemia and ovulated dysfunction, which might be due to PCOS.
No, basically, it indicates central obesity
Yes,
because
ma'am.
both insulin resistance as well as hypoandrogenemia are associated with central obesity. And hypoandrogenemia basically leads to central obesity, and central obesity increases the insulin resistance as well as leads to hyperinsulinemia. So what are the diagnostic criteria for PCOS both at ultrasound and at AMH and for AMH? And what are the fallacies with them being used as a diagnostic criteria? So according to the new international guidelines, just presence of irregular menstrual cycle and hyperandrogenemia, clinical or biochemical, is adequate for diagnosis. But when either only one of them is present, then you need to do either of these two. So what are the criteria according to the international guidelines?
Ma'am, the presence of any two of the following criteria, ma'am. One is oligo.
I'm just asking you, what are the diagnostic criteria for ultrasound and AMH?
Ultrasound. Yes, ma'am. And on day 2, the antefollicular count of more than 20 follicles measuring 2 to 9 mm, or in single view more than 10 follicles, or the ovarian volume which is more than 10 ml either in one of the ovaries.
And what about AMH?
AMH more than 5 nanogram per ml, ma'am, is more corresponding to polycystic ovary.
Yeah. What are the fallacies with both of them? What are the fallacies when you measure the antefollicular count by ultrasound, and what are the fallacies when you do a AMH value?
AMH with FSH, the AMH decreases with the cycle, ma'am. So we have to do AMH on day 2 of the cycle. And with the follicles, preantral recruiting, the AMH will be increased in polycystic ovaries, ma'am.
So what are the fallacies, but? How AMH values are affected and how ultrasound, the antefollicular count can be affected?
The expertise of the radio person who is doing the ultrasound, the machine probe, efficiency
so
of the
no,
expertise.
What is the frequency of the probe for having
8 megahertz TVS probe, ma'am.
And what are the fallacies when you're measuring AMH?
AMH with age, the AMH is reduced, ma'am.
No, when you talk about doing AMH value in a patient with PCOS, what are the fallacies? There are two things which can affect the AMH value. What are that? What is that?
Ovarian reserve, the number of
Apart from the assay, because there are different assays, but now you have to use the third generation because it has integrated everything. So that gives the correct value. Apart from age, apart from the assay, whatever, how is AMH affected?
the age, ma'am, with the age, the AMH will be reduced.
Age is forget, yeah, I'm not saying age, AMH reduces, I know. In PCOS, what are the two factors?
Because the main thing in PCOS is the most patients are obese, ma'am. So obese patients, the AMH is increased, and the
AMH is lower in obese patients.
AMH is reduced, ma'am. And patients who are having irregular cycles might be on using the oral contraceptive pills. So even that affects the AMH levels.
So in this patient, you've done the free androgen index. So is the level normal or abnormal? And what are the cutoff for suggesting that the free androgen index is high?
In females, if it is less than 0.7, it is normal, ma'am. But here it is 1.99%, so it is raised.
No, there is a range now for a normal. Which is significantly higher. What is it?
Uh, 0.7 to 1, ma'am.
No. So 0.7 to 6.4 is a normal range. So anything which is above 6.4 is supposed to be biochemical hypoandrogenemia. So this patient, basically, if she would have come with 2 years of infertility and she's just trying for 1 year, would you like to do her HSG right at the beginning when she comes? Or would you like to go for ovulation induction? How would you manage that patient?
Ma'am, if she comes with only 1 year, since trying, I would prefer to treat her with, like, first assess her ovulation, ovarian reserve and ovulation if it is happening or not. And then I would plan for ovulation induction. If doesn't succeed after 3 to 6 cycles, then I would like to further investigate it with HSG, ma'am.
What is the indication for doing HSG immediately after 1 year? Suppose she comes to you.
If there any history of...
You know she has PCOS, so you know she has anovulatory cycles. So normally if she just married for 1 year, we would not do an HSG. But there are a group of patients wherein you would like to evaluate the tubes before you induce ovulation. So which is this group?
Yes, ma'am. If there is any previous history of pelvic inflammatory disease or any childhood TB or presence of symptom signs suggestive of endometriosis, I would like to do hysterosalpingography.
And what about the symptoms, like any symptoms?
Symptoms like
on ultrasound or clinical examination?
Any adnexal
findings you're finding. I mean, the patient will complain of what?
Patient will complain of persistent white discharge or severe deep dyspareunia or dysmenorrhea during cycle, a chronic pelvic pain might be there.
Okay. So if this patient, anyway, she conceived in the first cycle, but suppose you had, she's ovulating with letrozole, so you continue letrozole for 3 months, yet she does not conceive. So would you straight go and give her gonadotropins, or would you like to give her clomiphene citrate and you would like to try? Or would you give clomiphene citrate only if she does not ovulate with letrozole?
I would like to try with for 3 more cycles at least for clomiphene citrate, ma'am. With clomiphene citrate, if she's not ovulating with letrozole, or if she's ovulating with letrozole and not conceived with before
Then
starting gonadotropins.
yeah. So what type of protocol would you use in a patient of PCOS?
PCOS, most preferably antagonist protocol, ma'am, because
Here we are just talking of timed intercourse. Now we are not talking of ART. Yeah? Why should you give antagonist and all?
So we will start with the leuprolide. Sorry, ma'am. I would like to give FSH from beginning at the low dose, ma'am. Step-up protocol is preferred in PCOS patients because the OHS risk is reduced if we start with low dose. Flexible protocol.
What are the complications of giving gonadotropins?
Like nausea, vomiting, and more dangerous complications like ovarian hyperstimulation syndrome, multiple
Gonadotropins cause nausea, vomiting? No, yeah, I don't think so.
OHSs and multiple pregnancies, no?
Yeah, OHSs and multiple pregnancies, right, but not nausea, vomiting. That is usually seen more with clomiphene citrate than with any role of using metformin.
Yes, ma'am. With metformin is acts as instant sensitizer in patients with PCOD, but the live birth rate and is not very different. Rather, using with along or not. But with gonadotropins, if we use metformin, the live birth rate is better.
It doesn't affect the live birth rate at all. Basically, it used for metabolic syndrome. And in which protocol metformin is beneficial? Whether it's beneficial with letrozole, clomiphene. That is for the prevention of OHSs. It can be used to prevent OHSs only in the GnRH agonist cycles. That's a different thing. Here we are not talking about ART at all. We are talking about non-ART cycles. So with which of the three ovulation induction drugs is metformin used as to increase results?
With clomiphene citrate, ma'am.
Okay. Thank you.
Thank you.
Then stop sharing your slides.
Yes.
Yeah. So today I would talk on physiology of ovulation. And I think that's the most important thing which you need to know, because all your stimulation protocols and your treatment, both in an ART and a non-ART cycle, are dependent on the physiology which is there. So all of us are aware now that any menstrual cycle has three phases. That is the follicular phase, where you have the recruitment and growth of the cohort of follicles that result in formation of a single mature follicle. Ovulatory phase, where there's final maturation and release of the oocyte, and luteal phase, where there's formation of corpus luteum to secrete hormones to support implantation. So in a normal menstrual cycle with changing frequency of the GnRH, as you can see that the frequency varies so much throughout the cycle, the integrated action of FSH and LH are then responsible for follicular development, as you can see over here, with secretion of estradiol, inhibin B and inhibin A. There's a pre-ovulatory surge of both FSH as well as LH, as you can see over here, before the ovulation. And there is secretion of progesterone, estradiol and inhibin A from the corpus luteum. So this very nicely signifies. So in the luteal phase, basically the GnRH pulses are low, and therefore the FSH and LH levels are decreasing. Thus, in the intermenstrual period and the follicular phase, the pulses increase, and therefore your FSH increases first. And once the E2 rises, as you can see over here, the LH also begins to rise. And before the ovulation, there is rise in the LH, FSH, as well as there's also a rise in the pre-ovulatory rise in the progesterone levels is seen. As you can see, this peak over here. And in the luteal phase, again, you have both estrogen and progesterone, which is secreted, and the pulse of GnRH decreases, and therefore your FSH and LH levels also come down. You can also see that the inhibin A and B levels. So inhibin A basically increases. Again, there is a surge during the pre-ovulatory period, and then it decreases, whereas there's also inhibin B, which there is increase in the luteal phase. The secretion of E2 and progesterone result in proliferative and secretory changes in the endometrium, preparing it for implantation should the conception occur. And in the absence of conception, the endometrial shedding follows the decline in the hormone secretion, secondary to the demise of the corpus luteum. And therefore, the hypothalamo-pituitary ovarian axis is the most important. GnRH is secreted by the hypothalamus via a neural mechanism which controls the pituitary as well as the gonadal axis, as you can see over here. And there is a remarkable coordination of hormonal secretion and morphological changes and cellular changes at various levels. So it is the anterior pituitary which secretes the FSH and LH. The FSH has action on the granulosa cells, whereas LH has action on the theca and later on the granulosa cells. And these granulosa cells secrete inhibin, which has a negative feedback on the pituitary. The estrogen and progesterone also have a negative feedback, and LH in the pre-ovulatory phase has a positive feedback. So basically, for the neuroendocrine functions, there should be a pulsatile secretion of gonadotrophin releasing hormone, which is released into the pituitary portal system to stimulate the synthesis and secretion of LH and FSH from the gonadotrophs. Gonadotrophin in turn stimulates follicular development and secretion of gonadal steroids as well as peptides, which have a negative feedback effect on the hypothalamus and pituitary, which restrain gonadotrophin secretion. And at the mid-cycle, the rising LH level is responsible for the positive feedback that generates the pre-ovulatory gonadotrophin surge. GnRH is basically a neurohormone and a decapeptide. It is released in pulsatile manner every 1 to 2 hours. Disturbed pulses are seen in patients who have stress, who excessively exercise, and when there is nutritional deficiency. And its deficiency can result in prolonged follicular phase, luteal phase deficiency, and ovulation, as well as amenorrhea. Coming to the gonadotrophins, they both FSH and LH have a similar alpha but a different beta subunit. They are released rapidly in response to GnRH, act on the granulosa, theca, and luteal cells in the ovaries to secrete E2 and progesterone, and the secretion depends upon the stage of the follicle or presence of the corpus luteum. So if you look at the hormones, so in the gestational, both the FSH and LH are high. And then as the child is born, you can see that the levels decrease significantly, and then they increase once after the onset of puberty, and have both increase and decrease depending upon the follicular phase. And once the patient reaches menopause, there is increase in the FSH and LH which is seen, and the FSH increase is usually more than that of LH. And if you see the pattern of FSH and LH, as we said, in the pre-pubertal, it is low, and during the reproductive phase, it is high. And you can see that the LH is significantly higher over here as compared to the FSH. But in the post-menopausal period, the FSH is significantly higher as compared to the LH, which I showed you in the last slide. So basically, change in the circuitry levels of FSH regulators, FSH secretory pattern, and post-transitional modification of FSH during pubertal progression, menstrual cycle, and perimenopausal transition is totally different. So during puberty, basically inhibin A and B gradually increase, follistatin gradually decreases. The FSH concentrations increase with advancing pubertal age, as you can see over here. And there is transition to more acidic isoforms during pubertal progression. In the follicular phase, basically high levels of inhibin B are seen, and there is constant levels of follistatin. Increasing FSH levels are seen until there is selection of the dominant follicle, after which the FSH levels again come down, and then again you have a small pre-ovulatory surge. The FSH during the follicular phase is has less acidic isoforms, which predominate. In the luteal phase, there are high levels of inhibin A, constant levels of follistatin. There's gradual reduction in the FSH levels after ovulation, as you can see over here, and there are more acidic isoforms which predominate. Whereas in the perimenopausal period, there are low concentrations of inhibin A and B, high levels of follistatin, and there is a persistently elevated FSH level, as you can see over here, and there are more acidic isoforms that predominate. So let us see what is the function of FSH. It is basically necessary for recruitment of antral follicles, selection and maturation of dominant follicles, granulosa cell differentiation and growth, activation of aromatase enzyme system resulting in estrogen secretion, FSH receptor increase on the granulosa cells, and induction of LH receptors on the granulosa cells. Whereas functions of LH are different in the different phases. In the follicular phase, it promotes androgen secretion in the theca. It has a synergic action with FSH in producing estrogen, and it supports the dominance once the FSH levels decrease. In the mid-cycle, it is responsible for resumption of oocyte meiosis, maturation of the cumulus oocyte complex, follicular rupture, as well as granulosa luteinization. And in the luteal phase, basically, it is responsible for maintenance of the corpus luteum and progesterone secretion, and it also induces endometrial receptivity for implantation. So the most important is for you all is to remember the 2-cell 2 gonadotrophin theory. So as you see over here, this is the oocyte. This is the cumulus complex, which are basically modified granulosa cells. Then you have the granulosa cell around which surrounds the follicular fluid, and surrounding that you have the theca cells, which can be divided into theca interna and theca externa. And if you see, look at the actions basically. So if this is the granulosa cell, it has only FSH receptors in the beginning. And once the FSH attaches to the FSH receptors, there's release of cyclic AMP. And then when in the presence of aromatase, the androstenedione, which is produced by the theca cells, is aromatized to estrone, and then which can also be converted to estradiol. And basically it is estradiol which is secreted into the blood. LH has its action on the theca cells in the early follicular phase, and in the presence of cyclic AMP, it converts cholesterol into androstenedione, which then goes into the granulosa cells. We'll also see the function of LH later in the late follicular phase. So as you see over here, you can see that there are LH receptors are there only on the theca cells, and there are FSH receptors on the granulosa cells. But as the follicle grows and it's about to rupture, where the meiotic division is happening, you can see that the granulosa cells also has LH receptors along with FSH receptors, where both of them have increased in the quantity. And this happens only in the dominant follicle. And you can also see that there is increase in the LH receptors on the theca cells as more amount of androgens need to be produced by the theca cells, which are then transported into the granulosa cells, because as the follicle goes, there's more and more of estradiol that has been secreted. So if you look at the key points then in the regulation of the hypothalamo-pituitary ovarian axis, So there are several points which we need to keep in mind. One is that for normal reproductive function, it is absolutely necessary for the pulsatile GnRH secretion to be within a critical range for frequency, concentration, and amplitude. The GnRH basically has only positive action on the anterior pituitary with synthesis, storage, activation, and secretion of gonadotrophins. The gonadotrophins are secreted in a pulsatile fashion in response to the similar pulsatile release of GnRH. Lower GnRH pulse frequencies favor FSH secretion and higher GnRH pulse frequencies favor LH secretion. Low levels of estrogen enhance FSH and LH synthesis and storage, whereas estrogen has very little effect on LH secretion and inhibits FSH secretion. High levels of estrogen induce LH surge at the mid-cycle, and high steady levels of E2 lead to sustained elevated LH secretion. Low levels of progesterone acting at the level of the pituitary enhance the LH response to GnRH and are responsible for the FSH surge at the mid-cycle, and high levels of progesterone inhibit pituitary secretion of gonadotrophins by inhibiting the GnRH pulse at the level of the hypothalamus. High progesterone levels can also antagonize pituitary response to GnRH by interfering with the estrogen action. Then we need to remember that apart from the hormonal system, the autocrine and the paracrine system is also very, very important. Here we have to know that the synthesis and secretion of the pituitary gonadotrophins are under control of hypothalamic GnRH, as well as influenced in varying degrees by activin, inhibin, as well as follistatin. Activin enhances and follistatin suppresses the GnRH activity. The gonadotrophin response to GnRH requires activin activity, and the gonadotrophin response can be blocked by follistatin. This relationship contributes to the downregulation of pituitary gonadotrophin secretion by prolonged GnRH stimulation. Increasing the GnRH pulse frequency first increases the FSH production, and then with sustained high frequency or continuous GnRH stimulation, follistatin production is increased. Selective synthesis and secretion of FSH can be explained by decrease in the inhibiting factor, inhibin and follistatin, allowing activin to enhance the action of GnRH, involving the transcription factor that promotes FSH beta subunit expression. LS secretion is primarily regulated by GnRH without involvement of the inhibin, activin, follistatin system. So if you look at the roles of all these factors, so inhibin A basically is secreted from the granulosa cell, from the antral or from our dominant follicle. The levels increase during the luteal phase, pregnancy, and in the presence of ovarian tumors, and it basically reflects the dominant follicular growth. Prenatal screening for Down syndrome, it can be used as one of the factors. It's also a marker for certain ovarian tumors. Inhibin B also is secreted by granulosa cells, but only by the small developing follicles. It is high during the follicular phase in the presence of ovarian tumors, and it decreases in the perimenopausal period. It reflects the total output of growing follicles, predicts response to ovulation, ovulation induction, and IVF, and it is also a marker for certain ovarian tumors and onset of menopause. Activins are secreted by the granulosa cells, pituitary, brain, as well as adrenal cortex. They are high in the luteal phase and during spontaneous labor. They basically inhibit progesterone production by the corpus luteum, may prevent premature luteinization, predict preterm delivery, and also relate to the lack of follicular development. Follistatin is produced by the granulosa cells and mainly by the antral follicles. It is low in patients with PCOS. It may vary in patients with PCOS, where it might be low or high, and it may relate basically to lack of follicular development. Then we have the other endorphins, basically the neurokine, dynorphin, as well as kisspeptin. So the neurokinin B has a role in steroid feedback control on the GnRH release. The dynorphin is an endogenous opioid peptide which acts primarily through the K-opioid receptors and is known to regulate the progesterone-mediated negative feedback on the GnRH release, whereas kisspeptin acts together with the NKB and DYN in a complex manner to precisely regulate the GnRH pulse generation in response to dynamic changes in the steroid hormone concentration. The kisspeptin, apart from stimulation of GnRH secretion, it mediates the negative and positive feedback effect of sex steroids on the hypothalamus, and its expression in the ovary mainly occurs in the granulosa cells in response to pre-ovulatory LH surge. LH surge also induces the expression of the full length of NTRK2 receptors, which with kisspeptin signaling drives oocyte survival through the PI3-AKT pathway, and kisspeptin stimulates steroid secretion by the theca and luteal cells. Therefore, a lot of studies are going on the use of kisspeptin as an alternative to HCG or GnRH agonist as an ovulation trigger. And if you look at the kisspeptin levels, they are low in the early follicular phase, whereas increase, as you can see over here, just pre-ovulatory, and then decrease further. And again, they slightly increase during the luteal phase. So basically, it corresponds more to the levels of progesterone rather than to that of estrogen, though with the pre-ovulatory estradiol increase, there is increase in the kisspeptin level. Coming to the autocrine, paracrine growth factors and cell-to-cell signaling in the follicles. So you can see that there are several cytokines and interleukins which are involved in the cell-to-cell communication between the oocyte, the granulosa cells, as well as the theca cells. So when we look at the TGF alpha and EGF, they are basically produced by the theca cells, and the site of action is in the theca, which is autocrine, and in the granulosa, which is paracrine, and are responsible for growth stimulation. Interleukin 1, 6, and 8 basically are secreted by the granulosa cells and the theca cells. In the granulosa cells, they have autocrine function, whereas they can have both autocrine and paracrine function in the theca and granulosa cells, and they are responsible for cell differentiation. TGF alpha is secreted by both the theca as well as granulosa cells and has both autocrine and paracrine function, and it results in growth inhibition, and it is also responsible for cell differentiation. IGF-1 and 2 are basically also secreted by both granulosa and theca cells, and it has both autocrine and paracrine function and is responsible for growth stimulation and cell differentiation. BMP, which is secreted by the theca cells, has a paracrine action on the granulosa cells and is responsible for cell differentiation. Inhibins from the granulosa cell have action on the oocyte, theca, and granulosa cells, both auto and paracrine, and are responsible for cell differentiation, whereas activins from the granulosa cells have an autocrine function on the granulosa cells and are responsible for cell differentiation. We must also know that, that there are different theories of follicular recruitment. One could have either continuous recruitment, where you have small antral follicles less than 4.6 millimeters, which are recruited to grow continuously at all stages of reproductive life, independent of the gonadotrophins. There's also another theory of cyclic recruitment, where some say that there is a single wave where you have 2 to 5 recruited once in the menstrual cycle. The follicles are comparable but not identical at all stages of development. Whereas multiple waves, as you see over here, where you have 2 to 3 synchronous growth of a group of antral follicle occurs at regular intervals during the menstrual cycle, and follicles in each wave are of similar but not identical diameters. And this is what we use when we use the double stimulation protocol. So coming to the follicular genesis, oocyte growth and development, we know that it continues throughout life from before birth until menopause, because we know that the maximum follicles are present when the woman is pregnant for her daughter at 20 weeks, that is 6 million. At birth, these are reduced. There are so many which undergo apoptosis, At birth, basically, you have 2 million left, and during till you reach puberty, you have only 2 lakh, because there are several which are again undergoing apoptosis. And then from puberty to menopause, at menopause, you have 100 to 1,000, about 400 oocytes would ovulate. So basically, it consists of the primary recruitment of the primordial follicles, and this is basically dependent on several factors. So PTN, FOXA3, and AMH are inhibitory, so they prevent the primordial follicles from becoming primary and antral follicles, whereas mTORC, SCF, BMP4 and 7, LIF and B, FGF are responsible for the primordial follicles to be recruited into primary follicles. The primary follicles then need to become secondary follicles and small antral follicles. It is stimulated by activin and inhibited by AMH. And then once they become small antral, they are all dependent on gonadotrophins till they reach dominance and a diameter anywhere between 20 to 24 millimeters, and then they ovulate. So what are the factors then involved in the progression of folliculogenesis? So basically, communication between the oocyte and their associated somatic cells is established with the primordial follicular formation. Granulosa cells proliferate during the ensuing stages of folliculogenesis. The oocyte granulosa cell communication mediated by the secreted paracrine factors and gap junctions is essential for development and progression of the follicles. Female gametogenesis and embryonic development after fertilization, and several factors function to promote or inhibit the specific stages in the progression. As you can see over here, that the MIS and c-KIT may prevent this, whereas from the primary to secondary follicle, again, you have the GDF9 and c-KIT, and between secondary or pre-antral follicles to pre-ovulatory, you have GDF9 and FSH, which stimulate the growth. So we must know that the total number of days for a primary follicle to become a dominant follicle takes more than 120 days. You have the primary recruitment or a tonic growth phase, which is almost about 85 days, from where the primordial follicle becomes primary and then a secondary follicle. This is endocrine gonadotrophin independent, and basically it's under paracrine growth. Whereas once they become small antral follicles, this phase is called as a secondary recruitment, and usually in a 28-day cycle, it's about 40 days. The small antral follicles are basically gonadotrophin sensitive, and once they reach dominance of 10 millimeters, they become gonadotrophin dependent, and as they grow, they are ovulatory after a follicular diameter of 20 millimeters. It is this secondary recruitment which is gonadotrophin regulated, and it is only this that can be modified with the use of exogenous hormones. The entire process, as I said, of folliculogenesis takes about 4 to 6 months, and the factors really responsible for a primordial follicle to become a primary follicle, the signaling pathways, which really control the squamous to cuboidal granulosa cell transition in follicular activation, are still not known. The number of primordial follicles are recruited from the pool of resting follicles for further growth, and then from pre-antral they become antral, and then they become dominant. The proportion of the pool of primordial follicles that is recruited for development increases with age and is related inversely to the density of follicles in the ovary. So if you have a low ovarian reserve, you will have more of the primordial follicles which are recruited, and therefore the patient, her AMH and antral follicular would reduce more faster in these patients rather than in those patients who have a good number of primordial follicles. The oocytes and the surrounding somatic cells undergo a series of changes that eventually result in the formation of a large antral follicle, which is capable of ovulating a mature oocyte. As I said, there is a plethora of the growth factors and cytokines that are involved in the primordial follicle activation. As I said, the inhibitors of cell activation are AMH and STF1, whereas there has several other promoters, as you can see from here. You have the LIF, GDF9, GDNF. You have then you have the PDGF, BMP7 and 15, BMP4, KGF and K-ligand, and FGF2, which are all promoters of development. And one must remember that there's a folliculogenesis clock that has been set by the oocyte. So all these activities, or whether the follicle is going to grow and ovulate, or it is going to undergo apoptosis, is decided by the oocyte. So it's important for us also to know the functions of AMH, because we know that AMH inhibits the follicular activation and growth. The FSH stimulated growth of the follicles, as you can see over here, the granulosa cell growth, as well as it also inhibits the AMH enzyme. So that is the reason why in women with PCOS who have very high AMH levels, they are more resistant to ovulation induction as compared to those who have low AMH values in the PCOS group. Thus, they are responsible for inhibition of primordial follicular recruitment and inhibition of FSH sensitivity. Then the other most important is the PI3K signaling controls the life and death of the primordial follicle. So elevated levels result in activation of the primordial follicle. Optimal levels result in maintenance of the primordial follicle, whereas suppressed levels results in the loss of primordial follicles. So this is a very important diagram which will tell us about how the activation of the oocyte is controlled. So basically, it is dependent on the KL and the c-KIT system via the phosphoinositide 3 kinase, that is PI3K, AKT, and this FKHRL1 and PTN pathways. So the oocyte PTN inhibits the PI3-AKT pathway, which allows the FKHRL1 to keep the oocyte quiescent. Binding of the KL to its receptor c-KIT results in phosphorylation of serine threonine kinase AKT system, and this activates the AKT pathway and inhibiting the activity of the FKHRL1 in the oocytes, allowing its activation, and this then results in meiotic resumption with accumulation of factors which are mentioned here. So the inhibition of the PTN trigger basically then results in PI3K activation, resulting in follicular recruitment, and therefore this is a very important factor which is seen in patients who undergo chemotherapy for cancer, because it inhibits the PTN and therefore it results in PI3K activation, and therefore more and more follicles are recruited, which then undergo apoptosis. Coming to the growth and maturation stage of oogenesis, the GDF9 and BMP15 act on the granulosa cells to modify the proliferation, function, and differentiation, and also activate the oocytes to grow. Once activated to grow, the oocyte orchestrates and coordinates the development of the ovarian follicle, and thus the rate of follicular development is controlled by the oocyte itself. As I already told you, that it itself has set a biological clock. So direct physical contact at the granulosa cell oocyte interface, that is between the cumulus cells and the oocyte, the main communication happens at that level. Coming to the early follicular phase, the FSH controls the major morphological and cellular events, and it is a principal regulator of follicular growth, whereas activin, which acts as autocrine and paracrine action, has an action in the pituitary, augments the FSH secretion and action, whereas LH negatively regulates the cell growth while positively regulating the steroid synthesis. Each follicle has a threshold beyond which it must be stimulated by the FSH, and each follicle has a ceiling within which it should be stimulated by LH. So all these follicles, the thousands of follicles will start growing, which are selected in the previously in the 3 months ago by paracrine and autocrine action. Basically, all the follicles will have different thresholds. So only those follicles which have a low threshold will start growing and will ovulate. Then when you talk about the LH therapeutic window concept, so if you have a normal LH level, they result in normal follicular growth and development, normal androgen and estrogen synthesis, and normal oocyte maturation. But if the levels are lower than 1.2 on D2, there's underexposure to LH. And then what does this result in? There's diminished thyroid production due to low androgen levels. The follicular maturation is impaired. There's poor cytoplasmic maturation and post-fertilization development. Endometrial proliferation is inadequate. And there's a 5-fold increase in early pregnancy loss. Whereas if the levels are more than 5 international units per ml, there's overexposure to LH, and this results in follicular atresia. There's premature luteinization and disturbed endometrial maturation. Oocyte development may be compromised. There's increased progesterone synthesis, basically in the follicular phase. There's decreased aromatase activity and decreased cellular proliferation. So, as just to summarize whatever I've told you, you can see that the small follicles, which are less than 5 millimeters, are gonadotrophin responsive, and they get recruited and they start growing. Once they achieve dominance at 10 millimeters, they become gonadotrophin dependent because they start acquiring LH receptors on the granulosa cell. They stimulate E2 production and they lower the FSH threshold. And once they reach 20 millimeters, they're highly responsive to both FSH and LH, and they grow and they ovulate. As you know, we have already discussed that FSH is responsible for production of inhibin A and B. LH is responsible for production of androgens and estradiol and has ovarian, autocrine, and or paracrine role. So, effect of LH in the follicular phase, we can divide it into two phases. In the early follicular phase, when the follicles are between 8 to 12 millimeters, basically it converts cholesterol to pregnenolone and then to androstenedione, which is then goes into the granulosa cells. And therefore, we can say that LH increases the androgen biosynthesis and stimulates the follicular recruitment. Whereas in the late follicular phase, when the follicles are more than 12 millimeters, LH receptors are found on the granulosa cells apart from the FSH, and they result in more and more aromatization of androstenedione to estradiol, and thus there's increase in the estrogen production. Thus, their function in the late follicular phase is increasing estrogen biosynthesis and stimulating follicular growth. So here, they basically result in follicular recruitment, whereas here they result in follicular growth. So with growing follicle, the hormonal profile totally changes. So it is much higher in the earlier phase and it decreases as the follicular grows. And therefore, as initially it was thought that AMH can be measured at any time of the menstrual cycle is refuted. And basically what we need to do is to measure it on day 2 of the cycle. And as the follicle grows, the inhibin B and estradiol secretion increase. So the increasing levels of E2 and inhibin decrease the FSH secretion, as you can see over here. So as the estradiol increases and the inhibin increases, the FSH secretion is decreasing, and insufficient FSH is unable to keep smaller follicles growing, which then become atretic and undergo apoptosis. Then you have the pulsatile release of LH, which is important. And in the early follicular phase, usually the pulses are very small. And in the late follicular phase, high levels of estradiol, typically of the late follicular phase, enhance the sensitivity of the gonadotrophs to the GnRH pulses, and therefore you have high levels of LH. So then what are the events that happen in the antral follicle? In the mid-follicular rise in the E2 exerts a negative feedback on the hypothalamus with decrease in FSH, and it has a positive feedback effect on the LH. Late follicular high LH stimulates androgen production in the theca, and FSH allows dominant follicle to utilize the androgen as substrate and further accelerate the estrogen production. Positive action of E2 includes modification of the gonadotrophin molecule with increasing bioactivity and quantity of the FSH and LH at mid-cycle. Progesterone reduces the GnRH pulse frequency in the E2 primed environment. High LH in the early follicular phase may therefore cause premature luteinization, premature activation of the oocyte, and it negatively influences the post-ovulatory events, resulting in poor quality oocyte, reduced fertilization and implantation rates, as well as high rates of miscarriage. Coming to the events in the pre-ovulatory follicle, during the LH surge, the estradiol concentration is usually more than 200 picograms. The sustained levels for it should have these levels sustained for 48 to 50 hours. This changes the negative feedback to positive one. There's occurrence of LH surge. LH surge is not accompanied by increase in the GnRH release. Late follicular progesterone rise happens before the LH surge and is important for the full expression of the LH surge. Apart from the small FSH surge which it results in, and there's mid-cycle increase in the local and peripheral androgen occurs, which are derived from the thecal tissue of lesser unsuccessful follicles. The LH surge results in resumption of meiosis, wherein M1 involves the segregation of the homologous chromosomes from each other, whereas M2 involves segregation of the sister chromatids that is analog to the mitotic division. Coming to the ovulatory events, the LH surge also stimulates luteinization of the granulosa cells and synthesis of progesterone and prostaglandin within the follicle. Progesterone enhances the activity of the proteolytic enzymes and together with prostaglandin is responsible for dilatation and rupture of the follicular wall, and progesterone influences the mid-cycle rise in the FSH that serves to free the oocyte from the follicular attachment to convert plasminogen to proteolytic enzyme plasmin and to ensure that sufficient LH receptors are present to allow adequate normal luteal phase. And as you can see over here, the meiotic division happens, and from two numbers you have a secondary oocyte wherein the first polar body is excluded, and the full meiotic division happens only after fertilization of the oocyte when the second polar body is excluded. So, if you look at the LH-mediated pathways to ovulation and luteinization, we know that it induces ovulation, COC expansion, oocyte maturation, and luteinization in the pre-ovulatory phase via the LH activation of the PK pathway, as you can see over here, and the NRIP1, which induces expression of EGF-like factors, which in turn activates the EGFR signaling cascade, including the RAS and ERK1 and 2, which is essential to turn off the FSH regulated gene expression program that controls the genes essential for pre-ovulatory follicular growth and differentiation. And the oocyte derived factors such as GDF9 and BMP15 affect the cumulus cells and granular cell function in a gradient-dependent manner. Coming to the luteal phase, which reflects the functional lifespan of the corpus luteum and is defined as the period from the occurrence of ovulation until the establishment of pregnancy or the resumption of menses 2 weeks later. It's a temporary endocrine gland with a lifespan of 14 plus or minus 2 days, and it is formed from the remnants of the ruptured follicle and is a major source of steroid hormone and secretes up to 40 milligrams of progesterone per day. In the luteal phase, progesterone, estradiol, and LH, all the three are very crucial. If you look at the role of LH, which is crucial in the luteal phase, it's totally responsible for the steroidogenic activity of the corpus luteum. It results in upregulation of the growth factors VEGF-A, FGF2, and cytokines involved in implantation, and it also results in stimulation of LH receptors in the endometrium. The luteal progesterone rise downregulates the number of estrogen receptors, thus indirectly suppressing the inhibitory effect of estrogens on the integrins. It acts positively by increasing the paracrine stromal factors, EGF and HbEGF, and it has a direct effect by stimulating the homebox gene HOXA10, which is implicated in the regulation of the beta-3 subunit expression necessary for implantation of the embryo. Thus, progesterone plays a critical role in implantation and development of normal pregnancy. So, what are the events then in luteal phase? It's optimum pre-ovulatory follicular development and continuous Tourniquet LH support, which is necessary. Progesterone acts both centrally and within the ovary to suppress new follicular growth. Regression of corpus luteum may involve luteolytic action of its own estrogen production mediated by alteration in the local prostaglandin and endothelin 1 concentrations. And if pregnancy occurs, HCG rescues the corpus luteum, maintaining luteal function until placental steroidogenesis is well established. Thus, successful implantation requires morphological and functional endometrial development, healthy normal embryo, embryo-endometrial synchrony, successful molecular dialogue, immune tolerance, and adequate hormonal milieu in the luteal phase, which includes both estrogen and progesterone, which is necessary to optimize the endometrial receptivity. Then coming to the events in the luteal follicular transition, the demise of the corpus luteum results in an adult in circulating levels of estrogen, progesterone, and inhibin. There's a decrease in A, which removes a suppressing influence on the FSH secretion in pituitary. Decrease in estrogen and progesterone allows progressive and rapid increase in the frequency of GnRH pulsatile secretion and removal of pituitary from the negative feedback suppression. Removal of inhibin A and E2 and increasing GnRH pulses combine to allow greater secretion of FSH compared to LH, with increase in the frequency of episodic secretion. Increase in the FSH is instrumental in rescuing approximately 60 days old group of ready follicles from atresia, allowing a dominant follicle to begin its emergence. We must also remember that hormonal changes during folliculogenesis are reflected as endometrial changes, and the endometrial thickness and morphology is a reliable bioassay of the patient's hormonal status, and changes correlate with the plasma estrogen and progesterone level. In the follicular phase, there's proliferation, as you see over here, thickening of the mucosa with increase in the cell number and size. Whereas in the luteal phase, there is arrest of the endometrial gland proliferation, and secretory differentiation necessary for implantation occurs, and it usually shrinks in thickness and it becomes more dense, echogenic on either side of the midline echoes. So we can summarize the human menstrual cycle as into the following ways, wherein the corpus luteum dies and the estrogen and progesterone level falls. The pituitary responds to the falling estrogen and progesterone by increasing the FSH secretion. The FSH recruits a cohort of large antral follicles to enter rapid growth phase. Follicles secrete low amounts of estrogen and inhibin. The estrogen and inhibin negatively have a negative feedback on the FSH levels, and therefore the levels decrease, and declining FSH levels progressively cause atresia of all but one follicle, leading to selection of a dominant follicle which produces high levels of estrogen. High estrogen has a positive feedback on the gonadotrophs, and especially LH surge happens. The LH surge induces meiotic maturation, ovulation, and luteinization, and the corpus luteum produces high progesterone along with estrogen and inhibin levels. And these high levels have a negative feedback on LH and FSH, returning them to basal levels. And the corpus luteum progressively becomes less sensitive to basal LH, dies if the level of LH activity do not increase. And this happens when there is no occurrence of pregnancy. There could be altered endocrinology in patients with polycystic ovarian syndrome, premature ovarian failure, and in patients who have poor ovarian response. So we can differentiate them. If there is a hypothalamic cause, we know that all levels are decreased. In ovarian failure and menopause, FSH and LH is high, whereas E2 is less. And in PCOS, the FSH could be either normal or low. The LH again can be increased or normal, and usually the estrogen levels are low because of the anovulatory cycles. And it's important how AMH can affect the response to stimulation. So if they are very low, that is less than 4, the response to FSH is poor, anticipated cancellation rate is high, and the pregnancy rate is also very low. When they are between 0.4 to 0.9, basically the response is reduced. There's increased cancellation, and there's also reduced pregnancy rates. When it is between 1 to 3, it's supposed to be normal. It has the response is good, cancellation rates are low, and the pregnancy rates also are normal. When the levels are more than 3, basically the response is very high, and therefore you can have increased incidence of OHSS. Cancellation rates are low, and the pregnancy rates are normal. And if you take antral follicular count also into account, apart from the age, they can predict the response, because after the age of 37 years, the response is usually poor. If the antral follicular count is less than 4, then the response is low. And if it is 16 or more, then you have a high response. AMH values basically 0.8 or less, you have a low response. And if it is more than 3.5, you have a high response. And if you look at the FSH levels, 8.9 or more, you have low response. And if it's 4 or less, you have a high response. So whenever you're stimulating, the follicular oocyte index is very, very important, wherein you have, so here you can see the normal follicular oocyte index has to be more than 50%. And if it is lower than 50%, then we say that they are hypo-responders. So basically, these hyporesponders, they have both AMH and antral follicular, which are normal, but they have a low follicular output ratio. That is, only a few follicles out of the growing follicles will grow and ovulate. And this low follicular FOI is basically associated with the low gonadotrophin starting dose, genetic or environmental factors, asynchronous follicular development, and technical issues involving the triggering for final oocyte maturation or even the oocyte pickup. There are other factors which can influence the hypothalamo-pituitary axis. So you have the sex steroids, inflammation, stress, drugs, and metabolism, which can affect the hypothalamus. You have the gonadotrophin inhibitory hormones as well as sex steroids, which can affect the hypothalamus as well as the pituitary gland. So I will conclude by saying that ovarian follicular development is regulated by the hypothalamo-pituitary-ovarian axis, in which the GnRH controls the release of gonadotrophic hormone FSH and LH, and that ovarian steroids exert both negative and positive regulatory effect on GnRH secretion. Other intra-ovarian signaling cascades affect follicular development and gonadotrophin action in a stage and context-specific manner. Most powerful intra-ovarian regulators of follicular development include the TGF-beta, SMAD, WNT, FZD, beta-catenin, and the RAS ERK1/2 signaling pathways, and the FOXA0 and the FOXL2 transcription factors. Ovulation involves perfect synchronization between neuronal, hormonal, and local events. Any disturbance in the events leading to mid-cycle surge and luteal phase can disrupt the local changes within the endometrium and hence affect the implantation. Endometrial preparation follows a well-documented pattern: growth in the first phase and decellularization in the second phase. The endocrine mechanism ensures monofollicular development in a menstrual cycle, and manipulation of these mechanisms are used for ovulation induction and superovulation. We have still 10 more minutes, so we can take questions. So you can either unmute yourself and ask questions, or you can post it in the chat box. So please, you can ask your questions. The first is whether you all understood what I said or it went over your head. And if whatever you've not understood, because this is the most important part, and therefore I normally like to take this lecture myself, because your entire treatment plan in the patient will depend upon the physiology of ovulation. Well, as we have already told you all, those who have their videos this thing off will be marked absent for the class. All your videos have to be on if you want to be marked present for the class. Even if you have any queries in the case what we have discussed, we can also discuss that.
Ma'am, Dr. Asha Bakshi ma'am is joining, no?
Right.
In 5-10 minutes.
Yeah, that's all. Please feel free to ask questions, okay? Now we have already finished 2 months of your term. So you only have now 4 months remaining. So whatever queries you had when you are seeing patients during those first 2 months. Yeah, so the fallacies of AMH and PCO basically is that we need to know that the in patients who are obese and the patients who are on oral contraceptives, they have low levels of AMH. And therefore, if you measure AMH during that time, you might not get the right levels. And therefore, you need to wait for at least 3 months before you measure the AMH levels again. Apart from the different assays which are there, because different assays can give different values.
Madam, can I speak?
Yeah.
I just spoke to Dr. Jaideep Malhotra. She has requested a change of slot.
Change of?
Slot. She is not available on 30th of April. I'll put it in the group also.
Yeah, then I'll just change. I'll see.
April I have finished. Everybody is confirmed except Dr. Jaideep Malhotra. I finished May also. No?
Yeah. Yeah, so if you have a functional cyst on day 2 of the cycle, basically it's best not to give her any ovulation induction drugs. You can either call her on the second day, because nowadays we really don't give oral contraceptives, or you can call her on the 9th day. Many a times when you call on the 9th day, the cyst is gone. And then after that, if any follicles develop, you can probably track that follicle. So the indications for doing earlier tubal evaluation. So basically that was a case of PCOS. So in PCOS, basically we know that anovulation is the main cause of infertility. And therefore we really do not require to do the tubal test, except when you find during the patient complains of chronic pain or she has dyspareunia, or when you're doing your clinical examination, your pervaginal examination, you have tenderness in both the fornices, and on ultrasound you can see whether there's an adnexal mass or there is any other pathology which is there. The patient gives previous history of any surgeries, then you have to probably go for tubal testing much earlier. No, you should take per ovary. The antral follicular count is basically per ovary, and antral follicular count per section is when you're doing in one section, how many follicles you see. So basically that is used for as a diagnostic criteria for PCOS. But when we talk about the prediction of response, basically it is the number of follicles per ovary that you need to see. So if they are less than 4 follicles, then you know that the response is going to be less. Between 5 to 14 follicles, it's normally normal response. And if it is more than 14 follicles, they usually increased risk of high response. So normal FSH and LH levels should be less than 8 on day 2 of the cycle. And if at all a patient is having a low ovarian reserve, and if you're going to go for ART, you have to measure her FSH levels on day 2 before you start stimulation. And you must stimulate them only if the levels are below 12, because if the levels are about 12, you're not going to get a good response, and therefore you need to cancel the cycle. So even if you have a functional non-functional cyst and the E2 levels are below, and it's not necessary that a functional cyst, the E2 levels may be high, but if you feel that it's an endometriotic cyst or a dermoid cyst, then you can definitely stimulate. So because you know from the appearance of the cyst, you would know what type of cyst it is. But if it is a clear cyst where you have a homogeneous plaque, you should not stimulate, because this can increase in size with your stimulation. Yeah, so AMH is not necessary if you have done an antral follicular count for diagnosis, but basically it should be done to select the right protocol if the patient is going to go for ART. So it is necessary in patients who are going to, because it's going to help us in predicting the response and therefore modulating our dose of gonadotropins. Usually, if it's a functional cyst, it will just disappear on its own. It does not persist in the next cycle. And if it persists, probably then you can give her a 1 or 2 cycles of oral contraceptives. And if it doesn't respond, then it's best to treat her surgically. I think all other patients except PCOS who are married for more than 2 years, have been trying for more than 2 years, one has to do tubal evaluation, because the 3 main tests which are required to be done in any infertility patient, the first is semen analysis, second is tubal evaluation, and the fourth is detection of ovulation, which which is usually done by doing a day 21 progesterone level, or 28-day cycle. But if she has longer cycles, you can repeat it every 7 days till she gets a menstrual period, and we'll know whether the patient is ovulating or not. Usually more than 3 nanograms is ovulatory, but our ideal luteal phase level of progesterone should be more than 10 nanograms if the patient has to conceive. As I already said, you should not do AMH on any day. It has to be done on the second day, because the levels decrease as the follicles grow. And it is a better marker than the antral follicular count, because it encompasses even the pre-antral follicles, whereas the antral follicular count measures only follicles between 2 to 9 millimeters. That is, they are little larger antral follicles. You can do a cyst aspiration in case you're sure that it's just a follicular cyst and aspiration in the same cycle. But
पता नहीं आएगा कि नहीं, रुकते ही नहीं है ना कई बार ये लोग.
But you can always wait for 1 or 2 cycles before you start stimulation, unless the patient has a low ovarian reserve. and then you want to stimulate her earlier, but you can always wait for 1 or 2 cycles. But if it is persistent, even after 2 cycles, then you can aspirate. नीलिमा, आशा बख्शी ज्वाइन किया?
Ma'am, she's joining
Hi
in 1
dear,
minute.
good evening.
हाँ,
Beautiful lecture.
thank you. So basically, it is said that metformin with clomiphene citrate is a good choice in the presence of clomiphene citrate resistance. They have done studies wherein they have compared letrozole with metformin and clomiphene with metformin. So they have found that there's no use of metformin when patients are resistant to letrozole, and it really does not increase. But if results in ovulation. But if you look at it, metformin does not increase the pregnancy rate in any of the 3 drugs, whatever we are using. Today, the role of PCO drilling is very, very less. We tend to avoid PCOS, the drilling of the PCO ovaries. We prefer to give gonadotrophins. But if you're doing a surgery for some other indication, you can always do drilling, but you must not do more than 3 to 4 punctures. And the current what you use has to be also very low. There's no role of any Placentrex in treating any functional cyst.
Hi Asha.
Hi, Suma.
Good evening.
Good evening.
और थोड़ा सा ही ज्यादा सा गुड इवनिंग मैम
Good evening. Good evening, Poonam.
Hi
Good evening,
Poonam
madam.
ji. Good evening.
मैंने गलत तो नहीं ज्वाइन किया, यही सही ज्वाइन किया ना?
सही ज्वाइन किया.
Yes, ma'am.
Acha, you can start.
है ना?
Huh? You can start to share your slides.
Okay. A very good evening to all, and I'm going to take a talk on etiology of female infertility. I hope, I think I've got another 40-45 minutes. Is that so? Dr. Pratik Tambe?
No, there's 1 hour for you.
Okay, fine. So infertility is the inability of a couple to conceive after 1 year of regular intercourse, and incidence is almost 10 to 15% of couples in reproductive age group. And in order to get good results with minimal target specific interventions, it is important to focus on exact etiology and treat it accordingly. Sometimes the etiology may be so simple that even with good counseling, only a patient may conceive. So it's not always that you have to do lots of investigations. If you talk to the patient and try to understand and reach the problem, then you may find out the cause, and just by talking, you may treat her infertility. And whenever we try to find out the causes for infertility, then I think we have to really consider the anatomy, and possible anatomical causes can be because of infection, anatomical causes, abnormality in the Mullerian duct, or tubal problems because of the adhesions and infection. There may be endometriosis, endometrioma, polyps, And then there may be other factors like semen parameters, but we are mainly today concentrating on female factors. And whenever you take history, I think a very elaborate history is very, very important. And this was a form that I had downloaded from ASRM site, and it has really given everything in great details. And if you really take this type of history, then things get very, very easy, and the diagnosis is right in your hands at the beginning. So it is right from the surgical to medical to vaccination to everything is written. And I think this is how a history should be taken, so that we really not just treat the infertility, but it's a holistic approach, and we can treat her on the whole rather than just treating the infertility. So, and usually what they do in this particular history sheet, they've taken history of male partner separately and female partner separately. And once they've given the history, then they take the signature of the patient, and at the same time, the physician who has taken the history, that is, he also signs. So that way, the history is really authentic. And I think we have to really think about something similar. And of course, we may not take such elaborate history, but then something we should devise in our own history sheet and try to make it according to our Indian scenario. But we should really take a detailed history. And these days, you people are so good in all this internet and all that. So maybe many a times you can send the form directly to the patient so that she can fill up the form at her ease. And when she comes to you, then the form is already there, all filled up, and only few gaps are there. So that would save your time. So what are the standard investigations? And we all know about all these things, but viral markers are important, because if you know from beforehand that patient has got hepatitis B or hepatitis C, then you can take all the precautions and treat the patient accordingly. Then blood levels are again important. How much importance to pay to FSH is really, I don't pay routinely, I don't do FSH. I do FSH only when I find that the follicles are really, enteral follicles are really low. And then in that case, between day 1 to 5, I may do FSH and estradiol together. But usually we tend to do thyroid, fasting blood sugar. And I think in our scenario, especially those patients with PCOS and otherwise in elderly patients also, it's very, very important that we do check the blood sugars, because India is again a diabetes hub. So, and we all know that if patient has got uncontrolled diabetes and she conceives, then lots of problems may be there. And I know about one patient who had frozen embryo transfer done. Before that, at the beginning, she was investigated, her blood sugars were okay. But when after 1 year or 2 years, her frozen embryo transfer was done. And at that time, she was frankly diabetic, and that was missed. And then lots of problems throughout the pregnancies occurred. So I think that all we have to keep in mind. Then a good transvaginal ultrasound. I think today a modern gynecologist is the one who can do her own transvaginal ultrasound, so that you can, the day the patient comes in, you know how is the endometrium like. And always whenever you write down the transvaginal sonography findings, then write on which day of the period you did that ultrasound, and that way you get some idea of the hormones also, and you can check for the ovarian reserve and good semen analysis. And in the past, it was that the gap should be 5 years or so, but these days the things are changing, and you don't need a gap of 5 days for semen analysis. Then talking about the other investigations, hysteroscopy, yes, in cases where on transvaginal ultrasound, you find something like thin endometrium or polyp, so then you can go for hysteroscopy. Laparoscopy, in the past, when I started my practice, we used to almost practically do laparoscopy for many patients. But these days, with good history, transvaginal ultrasound, the scope of laparoscopy for diagnosis has gone down. Still, we do HSG. But yes, if there is anything else that needs to be corrected, then we do laparoscopy and try to correct the thing. And one thing that we cannot diagnose very well on transvaginal ultrasound is the peritoneal endometriosis and the peritoneal tuberculosis. So these two things, all peritoneal problems are difficult to diagnose, but most of the things you can diagnose. And then male factors you have to investigate, and then HB electrophoresis should be done, because we do have many patients who have got sickle cell anemia and thalassemia. And a good pre-infertility workup is checking this also, because then this gives us an opportunity to find out what is the HB electrophoresis of the husband, and if this patient can go in for PGT also. So I think it's a good practice. And similarly, I think rubella antibody can be also checked, so that if patient is ready to wait, then you can give her rubella vaccine also. Then there are many causes of female infertility. The most important is coital dysfunction, and vaginismus is not an uncommon issue. And so many times you'll get these patients, they are well educated and everything. They've been staying together for years together. And when you go for transvaginal ultrasound, you find that you can't do it. And then she opens up that, no, we have been having problems with intercourse. So very important to ask about vaginismus. Vaginal dryness is again another cause of coital problem. Dyspareunia, maybe because of endometriosis, decreased libido, improper knowledge of fertility window, then ignorance of fertile window, then erectile dysfunctions in male, infrequent coitus. So all these things can lead to coital dysfunction, and it is a very delicate history. So you have to take the patient in confidence and be empathetic, and then talk to her so she will open up. Then coming to the ovulatory disorders, there are various classes of ovulatory dysfunction, and this, I think, from your undergraduate and postgraduate days, you know that there are three classes. One is class 1, hypogonadotropic hypogonadism, which is 5 to 10%, and these are basically patients who can ultimately, they do have good prognosis, and with gonadotropins, they can ovulate in future. Then there may be eugonadotropic hypogonadism, and that is PCOS, and these respond very well to ovulating agents. And the third is hypergonadotropic hypogonadism, and that is something like premature ovarian failure or menopause. And these patients, especially patients with Turner syndrome, initially they do have some reserve. So they tend to have menstruation, but then they tend to have early menopause, then ovarian resistance syndrome, and all these. And in these patients, oocyte donation is the option. Then PCOS is the most common endocrine disorders of the order of the reproductive age, leading to infertility, and is prevalent in almost 18% of Indian women. And the diagnosis is very easy by a good history about the prolonged cycles, and examination check for the acne, hirsutism, and then doing a good transvaginal sonography, which will tell you how many antral follicles are there, what is the size of the ovary, and what is the distribution of the antral follicles. And with all these things, you can pick up the PCOS, and you will know what sort of PCOS is there. And I won't talk about what mechanism of anovulation in PCOS, because you all know about it. But basically, there is supraphysiological levels of estrogen, strong negative feedback signals to hypothalamus and pituitary, low GnRH production with positive feedback on LH, low FSH and high LH, and no ovulation. So this is the mechanism. And the problems which are specific because of PCOS, one is that these patients, they tend to have more associated gestational diabetes also, preeclampsia also, miscarriage also. Then incidence of stillbirth is also there, longer time to conception, poor embryo development, decreased implantation, ovarian hyperstimulation, ectopic pregnancy, and many a times the eggs may not be that good. So there are lots of problems associated with PCOS and associated obesity, and many a times Even psychological problems are there, and the self-image, problems with self-image, and that may be again a cause of coital infrequency. And all these things can, in PCOS, lead to infertility. So then coming to the diminished ovarian reserve. And we all know that diminished ovarian reserve is associated with high rates of pregnancy loss regardless of age. And these women, they tend to have antral follicles less than 5 to 7. And usually their cycles are very short. And this could be one of the causes of infertility. And these are the most difficult cases to treat, because PCOS, okay, you can treat them, you can make them ovulate. But if someone has got diminished ovarian reserve, then it is very difficult to really rejuvenate these ovaries. So that's if I was to select between the two, I would select PCOS. So then prolactin hyperprolactinemia is another cause, and hypersecretion of prolactin leads to infertility and gonadal dysfunction by interrupting secretion of GnRH, inhibiting the release of LH and FSH, and impairing gonadal steroidogenesis. And prolactin inhibits estrogen synthesis in the ovary. In 20% cases of secondary amenorrhea, hyperprolactinemia prevents ovulation by impairing normal follicular development. And many a times when you find this thin endometrium, then in these patients also there may be hyperprolactinemia also. Then typical clinical presentation in these patients, in the premenopausal women, the prolactin is more than 31. And if it is between 31 and 50, then they tend to have short luteal phase, decreased libido, and infertility. Then between 51 to 75, then these patients, they tend to have oligomenorrhea. If the prolactin is more than 100, then these patients tend to have signs of hypogonadism, galactorrhea, and amenorrhea. And increased body weight is associated with prolactin secreting tumor. Osteopenia patients with associated hypogonadism, and degree of bone loss is related to duration and severity of hypogonadism. So hyperprolactinemia may be related, may be associated with bone loss also. So I won't be talking about men. Then luteal phase defect is again one of the causes of infertility, and it is, I would say, a vague cause of infertility, because it is very difficult to pick up the luteal phase defect. But it has been described since ages, and it was found that in the mice where there was no corpus luteum, then these mice could not continue the pregnancy. So luteal phase is defined as the period from occurrence of ovulation until the establishment of pregnancy or resumption of menses, that is 2 weeks later. Traditionally, luteal phase support is being given to IUI and IVF patients to improve implantation. Luteal phase defect is inadequate secretory transformation of the endometrium resulting from deficient progesterone production, implicated in both infertility and recurrent pregnancy loss. And the prevalence of a luteal phase defect in natural cycle in normo-ovulatory patients with primary or secondary infertility is 8.1%. So though progesterone, you can check the P4 levels, but again, that is also not confirmatory of luteal phase defect. Then tubal factors, the causes are tubal obstruction or occlusion may be there. Then there may be endometrial destruction, along with endometrial destruction. Then periadnexal adhesions may be there. Pelvic inflammatory diseases may be associated. Even in endometriosis, sometimes the tubes are involved. Then it is associated with ectopic pregnancy, and because of that, salpingectomy may have occurred, and that could be the cause of tubal factor. Then abdominopelvic, so this is an iatrogenic cause, abdominopelvic surgeries. Then use of intrauterine devices if it is associated with infection, and induced surgical abortions, again, if they are associated with infection, then they may lead to tubal factor. Then we know fallopian tube is divided into 4 parts, and it is 10 centimeters in length and has mucosa muscularis and serosa, and mucosa is further thrown into folds or plicae, maximum in ampullary region. And the mucosa contains columnar ciliated epithelium more than around 25%, secretory cells 60%, and narrow peg cells less than 10%. Then there are tubal telocytes, and these are often observed between smooth cell bundles, and they represent a functional unit by participating in making a primitive nervous system through telocytes, exosomes, gap junction cytoskeleton. They also participate in damage repair. They are decreased or lost in PID and endometriosis. And the author postulated that damage to telocytes may lead to infertility of tubal origin. So many times, even if the tube is appearing normal from the outside, there may be damage at the level of tubal telocytes. Evaluation of tubal factors. So how do you evaluate? So most of the methods which are there are they are invasive. And do we really evaluate tubes in every infertile patient? So here I would differ that not in every infertile patient, because I would really go for, in initial stage, I would go for evaluation of tubes when there is history of pelvic infection, prolonged fever, unexplained infertility, abnormal findings on TVS, ectopic pregnancy. These are the patients in whom we would go for evaluation of tubal factor at the earlier stage rather than. But because if you have got a patient with straightforward patient with male factor infertility, and the transvaginal ultrasound is normal, then I'm sure in initial phase, as a primary investigation, you wouldn't go for tubal factor. But of course, if you have to do some treatment or something like IUI, then you have to evaluate the tubal factor. So HSG still is a gold standard investigation, and I also believe a lot in it. And it is a fluoroscopic procedure, standard test for patency as per ASRM also. It has positive predictive value and negative predictive value for assessing is 38% and 94%. And if there is a unilateral block diagnosed on HSG, then what is the rate of clinical pregnancy? What is its effect on clinical pregnancy in IUI cycle? And this was a systemic review. In this, infertile patients with proximal unilateral block on HSG can expect similar pregnancy rates with controlled ovarian hyperstimulation and IUI as compared to those with bilateral tubal patency. Patients with distal blocks have lower chances of pregnancy. So out of the two, the cornual block is better. And otherwise also, even if someone has got bilateral cornual block and other things are normal, many times with a good hysteroscopic cannulation, you may achieve the patency of the tubes and the patient may conceive normally. Then laparoscopic evaluation used to be gold standard once upon a time, but these days I would say only where it is required. And it is, though it is not so invasive, but still it is invasive procedure. And but it is very good in the way it provides opportunity for diagnosis and at the same time treat. So you can say it is see and treat policy. And especially if the patient has got certain signs, you have done a transvaginal sonography, you can see adhesions of ovary with the uterus, or there is history which is suggestive of pelvic infection or something like that. And you can, or there are bicornual blocks on HSG and you're not sure, then I think those are the situations where laparoscopy still has its role, and it gives you very good results. And sometimes you can pick up these subtle tubal lesions which have not been described and given a lot of importance. But sometimes even these abnormalities like ampullary sacculation, fimbrial agglutination, non-connective adhesions, and abnormal tubal mucosa, fimbrial cysts, they are almost 19.4% in unexplained infertility. And when these are treated, then 50.7% chances of spontaneous pregnancy within 6 months. Also helps in preventing fimbrial torsion in cases of fimbrial cysts. So laparoscopy gives you an opportunity to treat these subtle lesions also, which are not routinely picked up on routine diagnostic methods. Then proximal tubal block may occur in 10 to 25% cases, and this can be because of tubal spasm, mucus plug, debris, salpingitis, ischemic nodosa, chronic salpingitis, tubal polyps, hypoplasia. The average time to become pregnant from natural conception or via clomiphene induction after successful unilateral or bilateral hysteroscopic cannulation is around 10 months. So we all have seen in our day-to-day practice also that cannulation does give good results, and especially if the patient is young and there aren't any associated problems, then it is worth doing cannulation. Then retained products of conception. These sometimes are, especially these days, patients tend to have these medical abortions, and then few products are left, and which we think that they will come out when the patient has the menstrual bleed, and many times they do not come, and patient is lost to follow-up. And when then you see, then you can see the RPOCs on the transvaginal ultrasound, and they can lead to inflammation as well adhesions leading to infertility. So hysteroscopy, diagnostic hysteroscopy, and at the same time removing the products POC is a very good procedure. Then genital tuberculosis is something, it has various types of presentation, but it is a very important cause of tubal factor in our country, leading to infertility. So genital tuberculosis is a chronic infection with long latent period, diagnosed late. Extrapulmonary form of tuberculosis remains silent. Early diagnosis for early institution of treatment is a clinical challenge, and it has become a notifiable disease since May 2012. So global prevalence is 8 to 10 million cases, and incidence is 5 to 10%, and in India even up to 17.4%. And so it is a very important cause of infertility in our country, and fallopian tubes are most common sites to be affected, and it can be in the form of endosalpingitis, exosalpingitis, interstitial salpingitis, salpingitis, ischemic nodosa. And hematogenous, it can be because of endosalpingitis, can be because of hematogenous spread, and tube is enlarged and thickened, and there is caseation in the wall. If there is caseation in the wall and blockage of tubes, it may lead to pyosalpinx formation. And if there is fusion of the papillae, then that can lead to infertility and ectopic gestation. And exosalpingitis spreads from intestines and affects tubal muscularis first. And initially, hyperemic tubes may be there, and later on, beaded tubes, calcified tubes, TO masses, frozen pelvis, and Fitzhugh-Curtis syndrome may be found. That is typical violin string strings with perihepatic adhesions. So whenever you do laparoscopy, always have a look at the liver to check for these. And when you may find so many incidental things. And interstitial salpingitis is interstitial part which is inflamed, and it is nodular thickening of tube due to proliferation of epithelium in the muscularis. Then even uterus is affected in 70%, endometrium is affected in 70% cases. And in initial cases, you may not find any macroscopic disease. In later stages, you may find some ulcerative lesions, some caseating lesions, and Asherman syndrome. And Asherman syndrome after tuberculosis is really very bad. And the whole endometrial cavity, uterine cavities becomes small and fibrosed. And they are usually very difficult to treat, and the results are very bad, especially if Asherman syndrome is because of tuberculosis. Ovarian involvement may occur in 10 to 15% cases, and there may be tubercles on the ovaries, TO masses, caseation, or sometimes ovaries may be completely destroyed. And there have been papers and they have shown that patients who have suffered from tuberculosis, they tend to have less eggs when you do controlled ovarian hyperstimulation for IVF. Then you get less eggs in patients who have got a history of tuberculosis because ovarian damage has occurred. Then causes of infertility in tuberculosis are mainly tubal factors and ovarian factors and uterine factors. Now, latent genital tuberculosis also affects the ovarian reserve in infertile women. And ultrasound findings is there. You may find hydrosalpinx, pyosalpinx, then hyperechoic areas in endometrium. You can see it here. Then distorted uterine cavity. You may find thin endometrium. Then you may find TO masses, enlarged ovaries, fixed adnexa, myometrial cysts. So these are all the signs on ultrasound. So whenever you see get such findings, then you should suspect tuberculosis in these patients. And these are visual. When you do laparoscopy, what do you find? So you may find corneal block, you may find beading of the tubes, you may find these tubercles that you can see here. These are the tubercles and beaded tubes you can find. Then you may find hydrosalpinx. You may find hydrosalpinx. You may find TO masses. Then you may find peritubal and peri-ovarian adhesions. And you may find caseous deposits on the peritoneum also. Then this is the typical violin string appearance on perihepatic adhesions. Then you may find tobacco pouch appearance of the fimbrial end. You may find fatty infiltration of mesosalpinx and perihepatic adhesions. The tubes may be lead pipe-like. There may be ascitic fluid and tubercles over peritoneum. So these are all the diagnostic things of genital tuberculosis with pus formation, hyperemia of the tubes and adhesions. So then fibroids is another thing which can cause infertility in 2 to 3% cases. And these days we all are following this FIGO classification. So out of this, the most common cause is because of the submucous fibroids, which are distorting the endometrium, and especially when these submucous fibroids are more than 1 centimeter. And even up to type 3 fibroids, these are the 2 to 5. So these are also, because here they do have some submucous component. So any fibroid which is more than 3 centimeters and is type 3 may have some submucous component, and this may lead to impairment in infertility. And usually subserous fibroids, they do not cause infertility, but if they are large and they are especially near the cornu and affecting tubo-ovarian relationship, then they can lead to infertility. And at the same time, there are some indirect effects of fibroids. There may be thin endometrium, reduced blood flow, innate ability to biochemically signal a surrounding environment, altered cytokine and growth factors, and reduced Hox genes, LIF, beta-3 integrin. So any fibroid which is causing menorrhagia will affect endometrial receptivity. And there are some studies which are saying that even chronic endometritis has an association with fibroids. So especially I've already talked about it, that type 3 intramural fibroids can lead to infertility, and submucous fibroids, we all agree that they can lead to infertility. Then, so these are all the studies which about the submucous fibroids. Then Mullerian duct anomalies. They have important implications in RPL, and the incidence may be as high as 25%. And the types of anomalies in RPL, the incidence may be very high, but they may cause infertility. And they may be bicornuate uterus, septate uterus, unicornuate, and didelphys. So they may cause implantation failure also, and that leads to infertility. And these are all the types of Mullerian anomalies. So this may be one of the causes of infertility. and you may get all sorts of septum. And sometimes if you diagnose them properly and if you keep in mind, then the results may be fantastic, especially patients who come with septum in the vagina, the transverse septum in vagina. You just excise that septum properly and patient conceives on her own. It is such a simple thing. And in these patients, usually when you examine them properly, you may not see any opening. But if you really examine them properly, then there may be a minute opening. And if from that opening you extend on all the sides and open it up, then you can beautifully see the cervix. So what you can do is when you do hysteroscopy, so basically you are doing a vaginoscopy. And you find this dimple, you go in that dimple, and then above that dimple, you'll see cervix sitting on the top. So it gives excellent results. And even septum also, if you resect it, then you get very good results. So all these anomalies may be there. And then this is about the uterine septum, and it is one of the commonest fusion defect, and it may lead to infertility. Then overall birth rates are 26 to 73% after the septum resection. So these are then cervical stenosis. Cervical stenosis is also one of the things which can lead to infertility, and especially if you are going to do IVF, then it may pose lot of problem, or even IUI. Sometimes the IUI is also very difficult. So in these cases, you can do hydrodilatation or hysteroscopic scissors, or with morcellation, you can correct it, and then you may get good results. And in olden days, people used to do DNC, and maybe in these type of cases, cervical stenosis, if you do a good DNC, the patient will conceive naturally also. Then T-shaped uterus is another abnormality, and that can also be diagnosed and lead to infertility. Polyps are an important cause of infertility. They are benign, localized overgrowths of endometrium. The incidence of asymptomatic endometrial polyp in infertile women has been reported to range from 10% to 32%. They can distort the endometrial cavity, may have a detrimental effect on endometrial receptivity, and increase the risk of implantation failure. And the pregnancy rates of 50 to 78% in previously infertile women have been reported after hysteroscopic polypectomy, and hysteroscopic removal of polyps prior to IUI increases the odds of clinical pregnancy compared to diagnostic hysteroscopy. Small endometrial polyps less than 2 centimeters do not affect the fertility rate after IVF, but a trend towards increased pregnancy loss. So basically, any up to 1 centimeter, I usually in my practice, if it is up to 1 centimeter, I tend to leave. But then if I'm doing IVF, then even smaller polyps I tend to remove. So it again depends since how long the patient has been trying, and if there aren't any other associated factors, then I would like to remove the polyp. No statistical difference in fertility rates has been observed in patients having polyps less than 1 centimeter. So I think there is a tendency to leave the polyps of less than 1 centimeter. Excision of, then sometimes the polyps are located at the uterotubal junction, and if you excise them, then there is significant improvement in the pregnancy rate. So this video, I think it must have played, and removing this type of polyp is really very helpful. And once you remove them, then because they act like valve, and if you remove them, then the patency is achieved again, and the results are very good. And intrauterine adhesions, 1.5% patients attending infertility have intrauterine adhesions. They are important cause of infertility, and the adhesiolysis is a hysteroscopic adhesiolysis is a gold standard, and genital tuberculosis, as I've already talked about, is an important cause in India. Then isthmocele is another cause which is being recognized as a cause of infertility, and it is, I would say, an iatrogenic cause of infertility, a secondary infertility. It appears as hypoechoic defect in isthmic region of the uterus on anterior wall, and can cause postmenstrual spotting apart from infertility. And symptoms, cervical stenosis may be related to infertility. So if you do a transvaginal ultrasound, and once you see this, then you know that yes, this is the patient who has got isthmosyle. Here you can see this. And if you take the history, because only since last, I think 7-8 years, we are talking about isthmosyle. Before that, we were not talking, though we were seeing the defect, but we didn't talk about it. But nowadays, we are talking about the niche or the isthmosyle in these patients and trying to correlate. Many times, they tend to have this post-menstrual discharge, pain, and all those things. And so, and this can lead to infertility. And this is about isthmosyle, and it has been shown that isthmosyle does affect the implantation rates. So cesarean, here this is again a study showing that large size cesarean section defect can significantly decrease the live birth rates. So in patients with secondary infertility, when you are doing with previous cesarean, when you are doing transvaginal ultrasound, please check for isthmosyle. And the outcomes are good, as you can see in this patient. Surgical treatment of an isthmosyle, particularly through hysteroscopy in patients with residual myometrial thickness of at least 2.5 millimeter, may be effective in treating isthmosyle associated secondary infertility. Now, endometriosis and infertility. So there is a cause and effect relationship. What came first? Is it the endometriosis or is it the infertility? So 25 to 50% of infertile women have endometriosis, and 30 to 50% of women with endometriosis are infertile. And prevalence of endometriosis is 6 to 21 times higher in fertility as compared to fertile women. And this is endometriosis fertility index, and this can be given only when you do the laparoscopy. So whenever you are doing a laparoscopy, then try to score the score through endometriosis fertility index. And if the index is, and then you have to find out the functional score of everything, of the tube, of the fimbria, of the ovary. And according to the fertility index, if the woman has got high EFI, then they have excellent fertility prognosis and may be advised to try to become pregnant with timed intercourse compared to women with low score, for which prompt referral to ART seems to be more reasonable. So whenever you do laparoscopy in a patient with endometriosis, try to do EFI, and this EFI will predict the fertility live birth rates, and you would know whether to send this patient for ART, for the IVF, or let her try naturally. Then hormone therapies for endometriosis, for infertility associated endometriosis. So are they indicated? Many things have been prescribed: oral contraceptive pill, progestogens, LNG, IUGS, antiprogesterones, GnRH agonists. But in infertile women with endometriosis, clinical should not prescribe hormonal treatment for suppression of ovarian function to improve fertility, because you're just wasting your time, and things are not going to work, and rather with time the ovarian reserve will go down. So instead, treat them actively with ovulation induction, IUI, IVF, and all those things, or let them try naturally. These days, people are talking that if you give dydrogesterone to these patients, then these patients may conceive at the same time. That may act as luteal phase support also. So that is the only thing that we can do. Then What is worse? Comparison of ART outcome between women with primary or recurrent endometriosis. And patients with recurrent endometriomas have similar ovarian response to controlled ovarian stimulation, embryo implantation, clinical pregnancy, and live birth rates as women with primary endometrioma. Surgical intervention for the sole purpose of ART outcome does not justify women with recurrent endometrioma, since the risk of complications is up. So if you see an endometrioma straight, you don't have to go for laparoscopy these days. You can consider treatments like IUI and IVF rather than going in straight, because with the excision of endometriomas, you are going to lose the ovarian reserve also. And coming to the fertility preservation technique, and women with endometriosis, if they are designed for extensive ovarian intervention, then these patients should be advised advised ovarian stimulation, egg preservation, and then they go for that. Unexplained infertility. We all know that average monthly fecundity in humans is only 20%. The husband may be normal, wife is normal, and cycles are regular. Still, her chances of conception are only 18 to 20%. Couples with unexplained infertility are thought to represent either a subpopulation of patients in lower extreme end of normal distribution of fertility, or a group of patients with a defect in fecundity not detected by routine infertility.
महाराष्ट्र तो ठीक हो गया, अब हरियाणा पंजाब
So what is unexplained infertility? Subfertility is said to be idiopathic or unexplained when a couple does not conceive and no defined cause of subfertility can be diagnosed after complete evaluation. And the incidence is 10 to 25%. Prevalence depends on the evaluation tool. After hysteroscopy and laparoscopy, the incidence reduces to 10%. Certain biochemical and molecular tests are there that can further reduce the incidence. It is a multifactorial disorder of reproduction. Many are based on disruption of biological processes that are crucial to functioning of normal endometrium. But basically, in our day-to-day practice, unexplained infertility means a patient is ovulating well, her semen parameters are good, and her tubes are patent. Now, implantation failure is another thing which is the cause of infertility. Everything is okay, but embryo is formed, but it is not implanting. And as you can see in this pyramid, that after fertilization, 30% embryos do not implant. If they implant, then 30% will have early pregnancy loss, 10% will have miscarriage, and only 30% will have live birth. So this is a very important pyramid, and you should all keep that in mind. And you all know about the stages of embryo implantation, which is a highly complex process involving a sophisticated crosstalk between the embryo and the endometrium, and it involves apposition, adhesion, attachment, penetration, and invasion. So any of these stages may not be working well, and that may lead to failure in embryo implantation. And even with an apparent euploid embryo, in case of IVF, pregnancy occurs only in 60% cases, and this can be because of hydrosalpinx, chronic endometritis, intracavitary lesions like submucosal myomas and polyps, EPLA syndrome, that is antiphospholipid antibody syndrome, PCOS, obesity, and smoking. And endometrial embryonic disc synchrony plays an important role in implantation failure. Maternal age and associated embryonic euploidy are of critical importance to embryonic implantation. So these are all the causes which can affect. This is the chart which is showing how the implantation can be affected. So the conclusion is a good history and examination during transvaginal ultrasound helps a lot in identifying the etiology. There may be a single or multiple causes of infertility. Once the cause is known, counseling and treatment becomes much easier. Thank you very much for the patient listening. Any questions? Yes. Any questions or anything you want to ask? Chats में है क्या?
I'm just looking at.
I was not prepared for this talk at all. I think I had given this talk 6 months ago or so, and today just when I was told in the afternoon I have to give the talk, then I opened it up just now.
So you did great job there. There are multiple questions. I don't know. Should we do per speculum and per vaginal examination at first visit for all patients? Obviously.
I think, yeah.
You
I think
need
this is a
active-
very good question, and for medical legal purpose
Yes.
also it is important. Though you are good at transvaginal ultrasound, but especially the per speculum examination is something which is very important, and you should really check for the polyp. You may see some Mullerian anomaly, as I said, that there may be a transverse vaginal septum, there may be a polyp protruding, or there may be some infection, a large cervical erosion. So all those things, and I think it's a very good idea again to take a pap smear also, because I
Yes.
know medical legal problem which occurred. This patient underwent IVF and carcinoma in situ was not diagnosed, and later on it was picked up and the doctor was sued. So very important to do a pap smear also when the patient comes for the initial visit.
Is there any role of SSG?
Of course, HSG is a very important tool, and especially if there is
Sonosalpingography. Yes.
Oh, SSG. Yes,
Yes,
SSG is
ma'am.
also a very good tool if you are good at it. And there are some people who are really very good at it and they do it. I am particularly not that great proponent of SSG, but these days very good media means you can really either you can use the saline or you can use the lactulose particles, and you can do transvaginal ultrasound at the same time and see the passage of the particles, and it delineates very well. So if you are used to, and if you, then it's a very good non-invasive procedure of checking the tubes.
Yes, Asha, I am a big proponent of SSG. I keep doing it. I have practically abandoned HSG, and I'm really happy to say the correlation between my laparoscopic findings and SSG is quite good. But you're absolutely right. It has some learning curve and some limitations, so it's not for everyone, and it's better to stick to HSG if not possible.
And you should have patience also. I think
Yes.
in your initial practice, if you have time, then I think it's very good thing to practice. You can use a pediatric balloon catheter, and or these days special catheters are available, and with that you can do, and you can. But the thing is, you should be proficient in ultrasound also.
Yes, that is very important. Next question is, if HSG shows bilateral blocked tubes, no significant history in the past, when to decide for diagnostic lab?
Again, it depends whether the patient is young or old, whether there are any other things at the same time. If she has got mild male factor and you are anyway going to go for ART, then there is no point in doing it. But if she is young and all the other factors are good, and you suspect that most probably it is a spasm or something, then I think laparoscopy is laparoscopic and hysteroscopic cannulation is a very it's a very good procedure, and it gives very good results. And I'm a great proponent of cannulation, hysteroscopic cannulation. And
Me too,
it
yeah.
allows the woman to conceive naturally. So you can leave the lady for 3-4 months, and you may see that she has conceived on her own. So I think it's a very good procedure.
On DHL, we see only fat-laden mesosalpinx. Does it mean TB?
It does not mean, but you should suspect. And in these patients, you can do endometrial biopsy and do gene expert to check whether there is tuberculosis. But if absolutely otherwise tubes are good, then maybe not. But then this gives some suspicion that yes, there may be fatty infiltration of mesosalpinx is one of the indirect signs of the. There are certain signs that yes, this is there, this is definitely, you can see the tubercles, hyperemia, this is definitely tuberculosis, but this is a sign which will have a lower score. So I wouldn't just put a coin to say that, yes, this is tuberculosis. But yes, I would suspect on that basis.
Okay. On what day of cycle should endometrium be measured, and how we go with thin endometrium? What's the role of AKT in thin endometrium? Which one is clinically better, aspirin or sildenafil for the same?
Hey Bhagwan. So many questions at the same time. But I would say that whenever you do transvaginal sonography, always put whether you have done transvaginal sonography on day 5 or day 15. So if you want to label somebody as thin endometrium, then you have to see that whether it is correlating with your follicle or not. So if follicle is 18, 19, and your endometrium is coming only 5, then this is a thin endometrium. So you have to correlate. Then other ways that this patient is already down regulated and she's on HRT. And with HRT, the endometrium is not coming, then it is less than 7 millimeter after giving, say, 15 days of estrogens, then that is also in endometrium. So there are, and now coming to AKT, I would never give AKT blindly unless it is diagnosed tuberculosis. So just because it is thin endometrium, I would not, or I would do laparoscopy to check whether there are any signs. So blindly these days you can't give AKT like that, and you have to notify this. So whenever nowadays I have stopped giving AKT on my own. If I diagnose on on hysteroscopy or on laparoscopy, then I send the patient to the person who is giving AKT. So to the physician. So I think we can't, because then otherwise we are increasing the chances of multi-drug resistant tuberculosis, and we know how bad it is. And we are, means India is having increased incidence of multi-drug resistant tuberculosis, for which nothing can be done. So very important to use all the antibiotics, all the AKT, everything sparingly where it is indicated. Don't just use the things blindly.
Ma'am, woman with unilateral tubal block and 3 failed IUI, any role of diagnostic hysterolab?
I think yes, you can do diagnostic laparoscopy, hysteroscopy, or you can straight away go for IVF also. So it again depends on the patient's pocket and if there are any other reasons for which you want to do IVF. Because once it is 3 to 6 IUI, how many IUI you are going to do? And nowadays we are all so proficient in doing IVF that we wouldn't just waste a lot of time in doing IUI. But whatever said and done, still I like IUI and it is a good procedure.
Ma'am, if TB gene expert of endometrium is negative, does it still rule out TB salpingitis? Very good question.
No, it does not rule out. But see, if it is an old tuberculosis and tuberculosis and it has been treated, still the anatomical damage that has occurred will always remain there. So if endometrium is good and TB PCR is negative, and there is a history that she has been given anti-cox treatment in the past, then I may not give her anti-TB medication anymore.
And in chocolate cyst, till what size we can go for conservative management and can do ovulation induction?
See, usually up to 5 centimeters, 4 to 5 centimeters you may go, but again, you have to be very good in transvaginal ultrasound. You should not miss any carcinoma because sometimes even cancers can be missed. So if you are good and you are very confident, then up to 4 to 5 centimeters you can leave and try naturally or IUI or go for IVF also. If you feel that it is very large and when you are going to do IVF, then it will rupture, you may not access the follicles, then it is worth doing laparoscopy. So because laparoscopy is again going to ovarian, when especially you do cystectomy, then sometimes the ovarian reserve goes down. So you have to balance out everything and see. So the biggest advantage of laparoscopic excision will be that you have got a tissue diagnosis. So you will never miss a cancer. But then again, you should be able to pick that up on transvaginal ultrasound.
What is the role of AKT post previous ectopic pregnancy or only based on hydrosalpinx in laparoscopy? Should we give AKT in such patients?
hydrosalpinx, and if there are some other associated findings which make you say that yes, this patient has got tuberculosis, I would treat her. But otherwise, I would not give her AKT. I would just go for other treatments.
Post-ectopic.
Post-ectopic pregnancy. So I would investigate her
Yeah.
for chronic endometritis in such a case. These days, investigations are there to investigate these patients for chronic endometritis, and many a times you may find the causative agent also.
Okay, I think that's it.
Because RNA PCR facility is available, and maybe soon NGS will come, and you may be able to exactly diagnose what organism is there. You may do CD138 at the same time, and that may again tell you whether this patient is having chronic endometritis. So if there is thin endometrium, if there is thin endometrium and there is evidence of chronic endometritis, then you'll treat it accordingly. But one thing I'll tell you that TB was very, very common 15 to 20 years ago. But slowly I'm finding that the incidence, I don't know, in my own practice, I'm not seeing that much of TB as I used to see 20 years ago.
That in continuation with tuberculosis, what test for diagnostic test for tubal TB, and then what test for chronic endometritis?
Gene expert you do on endometrial biopsy, and chronic endometritis you can do endometrial biopsy, and that is usually you do around in luteal phase, more in the luteal phase, and in that you may find on RNA PCR the organisms. Then at the same time you can do plasma cells, you can do the immunohistochemistry and check out what is the number of plasma cells, and if it is more than 5, some people are taking cutoff as more than 3. So if it is more than 3 also, then that shows that this is chronic endometritis.
Yeah, ma'am, should we do endometrial biopsy to rule out TB before we do HSG in cases of hydrosalpinx on USG?
So see, if there is hydrosalpinx on USG, I would rather not go for HSG. What is the point? Either
Yes.
for laparoscopy, because that would be more helpful. Why go for HSG?
Okay. Thank you, Dr. Asha. It was very elaborate discussion followed by you patiently answered all the questions.
I think Madhuri is saying something. Madhuri, you are mute.
I can't see though. That's why I took over the questions.
Yeah. Madhuri, are you saying something? I don't know. She's mute, so maybe she's talking to the patient.
She'll conclude this session, I think. But I can't find her.
No, I can see her, but she's on mute. Madhuri, you are on mute. She's speaking, but I can't find her. So I think is it okay? Let's wind up. Any more questions? I think you can message. Can you text Madhuri?
Sorry. EB, they are asking endo biopsy with hysteroscopy. Is it mandatory? I said yes, it's okay. If we are going in, then you should be doing it.
Yes. But one thing I tell you that if you are going to do endometrial biopsy for chronic endometritis, then better to do it before doing hysteroscopy, because what happens with hysteroscopy, you are using this saline and that will irrigate the endometrial cavity and it may wash away the organisms. So I was discussing, and especially these days, we all are in the habit of doing vaginoscopic hysteroscopy. So that fluid is going through the vagina and through the to the endometrium. So that is going to alter the picture. So what we do usually is we do after cleaning and painting, with the help of PIPL, we take the endometrial biopsy and then do hysteroscopy. I think we will wind up. Okay. All the best to all of you, and I'm sure you'll have lots of other lectures and you'll learn a lot. At the moment you are beginners, so what many things might have gone above also when I'm talking, but then slowly you'll listen to these things again and again, and then you'll understand what I was talking. So bye. Thanks.
Thank you, ma'am.
Thank you. Thank you, Seema. Thank you, Madhuri. Thank you, Pratik.
Bye.
Pratik is not there, so thank you.